First of all, I'd like to thank Meryl for giving me this opportunity. Good morning to the chairpersons. This is more of a philosophical talk than the technical talk, how to shorten the learning curve. My experience of my first 250 cases. So first of all, what we need to change is our mind. Just been running behind time, like how to finish it in 20 minutes, 25 minutes. But if we are shifting to robotics, then we have to weigh the advantages versus the time taken. Time taken will definitely come down. It will come down to 40-45 minutes, what we normally do for our conventional TKRs. But we need to weigh the advantages. We have advantages that we can plan with the CT-based system. We can get a more natural feel because what I plan is I plan on a CT to put my implant in a native position as much as to match the anatomy of the patient, the trochlear groove, so that there is no patellar stuffing. Try to remove less and less bone. And the belief in the technology actually strengthens by the results of it. But before jumping into it, we should know how to use it. So train well before you actually jump into it. Visit surgeons who are actually doing it, learn the technical know-hows, and the most important thing is until you start believing it yourself, you know that the results are better. The patients actually read it from your face. So if you want to sell it, you actually need to believe the concept. Sorry. Training and understanding. So we need to build a relationship with the robo. So your robo is no less than your girlfriend. So you need to take care of it, understand its emotions, and it will slowly also understand you. Be patient. There will be times you like to scream, you'll shout, you'll swear, you'll cry. That's what I have done. But as you give time, as you stay patient, you will fall in love with it, and you'll slowly want to marry it too. When we get results, what we aim for, a patient who wants to do bhangra on a third day, what else do we wish for? These are the results we aim for. So these results actually strengthen your belief in this technology. So I think all of us here, we can be part of the next revolution. So we need to eat, breathe, live robotics, and if you believe in this concept, I think everybody will start believing. A little bit on the technical part. Pre-planning is very important because I've heard seniors saying if you put shit inside something, shit will come out. So plan well. If you're planning well, your results will be well. In this, we can actually, if you see the numbers, try to cut minimum. For the QVIS users, try to keep the posterior femoral cuts around 7 and the tibial cut from 3 to 5 because you have to add half the diameter of the burr as well to it. The things which we actually neglect as surgeons, we just reach inside the OT, everything is raped, everything is ready, but your technical staff needs to know these things because if your sleeves and your chucks are not cleaned well with the air guns and with the solutions, you will have force freeze errors because there will be some particles inside the sleeve and they actually get irritating because you want the robot to cut and it won't cut, it will stop. So these things also need to be taken care of if you want to have a smooth surgery. Always stay attentive because जब सावधानी घटी दुर्घटना घटी because sometimes the robo wires get tight, the drapes get stuck. So every time, sometimes your motor will get loose because it is a mechanical thing. So keep your eyes on the robo, see how it's going, and you won't get stuck. So initially you'll get some errors, but slowly you'll know what errors, what to do, and I think slowly the things start getting smoother. The femoral pin insertion is very important because slowly I started with the shaft pins, but there are complications. The fracture risk is real. I had 2 fractures in my 100 cases, shifted to metaphyseal pins, and ever since in the next 175 cases, we didn't have any problem. The problems with the shaft pins is, first, the stress fracture risk is there, and that happens mostly in the 2nd or 3rd month, not immediately. obese patients, when they breathe, it actually touches the femur areas, and that is actually, you have to press down on the stomach. It gets irritating. So since shifting to the metaphyseal pins, these problems don't happen, as well as when there is water splashing around. With the shaft pins, it actually contaminates the areas more. And with the distal application in the metaphyseal area, this problem is also avoided. So this is the most important set, as Dr. Rohan also mentioned. Position your arrays well, all looking towards the OTS. And if you have a good arrays, you won't have a trouble in the registration process and during the robo cutting. Put all the, check in the range of motion, in extension, in flexion, in every range of motion, that both the femur and the of all the three systems. And the gap check, most important. We normally give a varus thrust, valgus thrust in both flexion and extension and check the gaps. But in some cases, when there is a little tightening is there, the femur and tibia are so conformed, so there would be numbers which are actually less. So I normally put an osteotome on the lateral side, try to tweak it a little, try to give it a more varus thrust. It gives the numbers which are actually real. So you could either put a laminar spreader inside or an osteotome and get a proper gap check. Otherwise, you might end up cutting more bone. So know all your options you've got. You've got a lot of options. You can rotate internally as well as externally. You can flex and extend. You can do a varus or valgus in both tibia and femur, as well as you can make it anterior up, distal up and down. And another thing I would like to point is the rotating origin. If you keep it laterally, you are hinging your movement, varus or valgus, on the lateral side, and you will be closing or opening up the medial side. Or if you keep it on the medial side, you will be closing or opening up the lateral side. So that is what you need to keep in mind, so that it is your call. You want to decrease some figures or you want to increase some figures. So that is a very important point. Metaphyseal pins to connect the robo to the patient. Put it anywhere, it will connect. So there is no skill involved in it. It has just to be metaphyseal and not come in sometimes your tibial preparation. Robo positioning. Just a sec. This part actually takes a lot of time initially. So as your assistant gets trained, he knows how to bring the robo in. The trick is all these three arrays need to be facing towards the OTS. The robo array should be away, and you need to have all the reds and whites. On these two circles need to have them in the center. The RX and RY are the flexion and the rotation of the leg. So sometimes initially we don't know what these things are, but as we start to do, we know how to keep, how much flexion to keep, how much of the rotation of the leg to keep. So it is all a part of the learning curve. Sometimes we need to innovate, because while cutting the tibia on the lateral side, in a fatty patient, sometimes the robo will get stuck and you will get a force freeze error. So in such cases, we normally put stacked Hoffman retractors so that they don't come in front of the array as well, and you get a good retraction for that as well. So sometimes we normally feel that OTS has to be in a very good position, like the X marked over here. But when you're cutting the femur, all you need to see, the OTS needs to see both the robot and the femur arrays. So sometimes you have to go unconventional positions. So don't be scared of the OTS. You can move it around. It is not to be fixed in one position. It just has to see it trackers so that it can do the cuts. So unconventional is also fine. Keep changing OTS as it suits you. So safety, the robo is very safe. It works only in the area which it is told to, and it also leaves a 2 mm margin so that there is no error. Slowly you will start trusting it. You won't put retractors in. 90% of my cases, I don't need to put a medial retractor or retract the patella or put a retractor anywhere in all the cuts. We have a verification option. Whatever cuts we take, it's important to verify, because sometimes there is a medial sclerotic bone. It might not go fully with the burr. So if you feel there is a point few varus valgus left, so you could actually do it manually and also verify it then later. So how to shorten? The more you do, the more you learn. So it is about getting in the OT and doing it on a regular basis. So for that, you need to build the numbers, and once your numbers are high, you need to work on your workload, and time management is very important, how you space your cases. For a good number, you actually have to go have a good launch. That is, well begun is half the job done. Then we have to build a team who knows their jobs. Everybody has their roles. This saves a lot of time, because more than your training, it is your team's training that is important. They need to know what to do, because you will get trained faster, but your staff will take around 40 to 50 cases to get aligned with you. So that is when you started saving time and your frustration levels come down. And then marketing. Everybody knows marketing is very essential. You need to go unconventional. I try some innovative things. You cannot bombard people with all the technical stuff and know-how, because they would understand what is a gap check, what is what. So it is your way, how you connect to it, but you cannot replace good results. You have to go give good results, and that you have to deliver, simple. The relationship with patients is very important, because they are our most important advertisers. You have to be good to them, and in the post-op phase also, just have a good relationship with them. Family support all the time is important, because you can't do anything with your family, because without your family, that helps saving frustration in those hard times when you are actually building a relationship. Your wife should be fine with you having a mistress with you. And learning by teaching. The more you teach, the more you discuss on table, the more you learn. So keep your mind open to learning and discussions, because every time you are teaching, you also discuss and you learn something new. Max, Merrill is always there for your help. There are robotic training programs which you can do before you get your robo. And then once your robo is with you, there could be surgeons visiting you as a proctor, so that they can guide your staff as well. Webinars are there monthly, so that everybody, the new surgeons actually get a know-how of how to do things, what their doubts are. They can connect with people who are actually doing it since long. And whenever in OT you are stuck, they have tech support which you can call, and if there is any error, they are mostly available on time, so that you get out of it. In the summary, just practice, keep track of your progress, get feedback, get people coming in your OT who have been doing it, and they give you feedback what you can change. Study about it, not much material available, so you can discuss with the people who have been doing it and teach what you've learned. I think that is the best way of learning. Thanks for a patient hearing.